The first one I've got here is Dr. Kavadra, so you can have a go. There you go. Cool.
Oh, hello. Can you hear me okay?
Is that all? Yeah?
Hello. Hi, everyone. So my name's Babu. I'm currently going into ST3 in Obstetrics and Gynaecology from August. I'm not sure, Quadzia, sorry, is our introduction meant to be our presentation, or is it just a quick hello, really?
Yeah, so your presentation, and we'll go around, we'll do the presentations, and then we can get all the questions in as well.
Perfect. Okay, so for my one, if you just move to the next slide, there's only one more slide after this, really, for my one.
Yeah. That one?
Yep, just one more. Yeah, that's it. So, like I said, my name's Babu, currently going to be an ST3 from August in Obstetrics and Gynaecology. I initially trained at the University of East Anglia. Prior to this, I did a degree in biomedical sciences in London. Completed my medical degree in Norwich and did the academic foundation programme again in East Anglia. It's involved a bit of public health as part of my academic rotation. I didn't really have much to do with obs and gynae actually during my foundation years. There's not that many rotations with obs and gynae, but I did a taster week. I did my medical electives in obs and gynae, and then ended up applying for specialist training. So my training is purely based in the Eastern Deanery, so quite a large deanery with lots of different hospitals of districts and district generals and tertiary hospitals. So at the start of my second year of specialty training, I decided to take some time out to do research as a clinical research fellow. So that was 3 years out of program, and that was to do a PhD in endometriosis. So I've just finished that, and I'm just writing up my thesis. And I've now returned back to full-time clinical training during COVID times. So I'll just let the next speaker go forward.
Sorry, Katie, are you good to go? Oh, I think she might be having some problems with the. What I can do is we'll move on to Abrar. Do you mind introducing yourself and then?
Okay. So my name's Abrar Elniel. I am the most junior person, I think, on this panel. I am an FT doctor. I'm currently working at accident and emergency, so I have 2 more days, and then F2 is over for me. And from October, I'll be starting ST1 of Obs and Gynae. So I put this little timeline here for other medical students, like to kind of see how my timeline has been. So I studied medicine at King's College London. I also did an intercalated BSc there. And then I moved to Manchester to do my foundation training. And I didn't think I wanted to do obs and gynae, but I knew it was something I really enjoyed. So I decided to choose to do an obs and gynae placement. So one of my jobs, my first job in F2 was an obs and gynae, and that completely changed my career trajectory to decide to do obs and gynae. So I applied for that last year during my obs and gynae placement, and then fortunately I'm going to start training in that from October. So if you just go on the brief next slide, could you for me? And I just want to kind of like explain for medical students, like what I think is really, from my journey, it seems quite linear in that I went from one step straight to the next, which is the traditional way, but it's more and more unconventional because I am like one of a few F2s in my cohort actually going straight into training. But it's all about, like, for me, even though I didn't want to do obs and gynae, I've had a lot of really positive experiences in it that completely changed my mind about it. So from work experience before uni, my placements during university, a summer school in obs and gynae that my university offered, my placement in it. So all of those things just kind of can help inform what I wanted to do in the end. So that's how I came to obs and gynae.
Nice. Okay, we've got a few questions coming in, but I think I'll let Anna introduce herself as well, and hopefully Katie will be back by then, and then we can go. So there you are.
So yeah, sorry, I've got my branded slides there because I'm here to plug some opportunities that we've got coming up with BUSOG. So do you want to go back just to the one that just has my name on it? Is that okay?
Yeah, no, of course.
So yeah, I am here representing the British Undergraduate Society of Obstetrics and Gynaecology, which I'm president of for the next 2 years. And I am a final year medical student studying at King's College London, actually. I have been on a year out the past year because I've been working at the British Medical Journal as editorial scholar, which means looking after all of the content the BMJ produces for students. So the kind of other side to my interest is medical journalism and medical editing and things like that. But my clinical area of interest is in obstetrics and gynecology. And yeah, I'm hopefully going to take you through some of the opportunities that you have at quite an early stage, and also some opportunities we've got coming up through BUSOG and how you can get involved with us. So I don't know if you want me to do that now and then do questions, or
you can do that. Any questions they have from what you've said, we can after you've covered everything.
Okay, cool. So yeah, I guess from the point of view, of me, like being a fellow medical student, I'm not going to be able to give you any insights into like applications or anything because I've not done that process yet. But there were a few things that I just wanted to say about how if you have an interest in obs and gynae from an early stage, you can get involved. And I think some of them people were probably quite obvious, like obs and gynae societies and SSCs in obs and gynae, and expressing interest during your placement. But just a few things that I have done kind of in my time at medical school to kind of increase my exposure to obs and gynae is actually expressing interest in other placements. So for instance, when I was on my general surgery placement, I asked my consultant who I was with if I could spend some time with the gynae team. When I was in A&E, I made sure that like my supervisor knew that I was interested in obs and gynae and women's health. And so often if there were cases coming in that looked like they had a kind of obs and gynae presentation, they would ask me to go and see those patients. Anesthetics, obviously there's a huge anesthetic input into obstetrics, and obviously gynecology is a surgical specialty. So I think there's a lot of opportunities for getting a bit of exposure even outside of your specific obs and gynae placement. So I know for me, I did obs and gynae like right before my 4th year exams, which are like the big exams at King's. So yeah, there's definitely ways that you can get involved in other places. And yeah, at the moment with BUSOG, we've just opened applications for our ambassadors program. So we're recruiting at least one ambassador from each medical school and at least one pre-specialty ambassador as well. And you can find out all about that on our social media, which is there for you. And yeah, we'd love to read your applications, and we've got some events coming up as well, which yeah, if you follow us on our social media, you'll be able to keep up to date with what we're doing.
Perfect. Thank you so much for that. I think I'm not sure if Dr. Katy Sutcliffe will be able to join. Hopefully she might be able to, like someone will help her on the other side. But in the meantime, so we've had some questions. Actually, you might have answered it already, Abrar. But just generally speaking, talk about what actually led you to pursuing obs and gynae, what you think when you were deciding as a foundation doctor, and actually you, Abrar, because you decided quite late, what was the pros and cons when you thought about it? I think that'd be quite interesting to talk about.
So when I graduated from uni, I thought I wanted to do ophthalmology, and it's something that I held on to until F2. But I had I'd had a lot of experiences in obs and gynae, which I always enjoyed. So I remember from my work experience before university, I spent a day with community midwives, checks. I saw a cesarean section on my work experience, and I thought this was all so incredible. And I really enjoyed my preclinical reproductive and sexual health block. Like at the time, King's was more separated into preclinical and clinical, but it's a bit merged more. And then I had my women's health block, which was excellent. Like I did it. I had an incredible supervisor. I had so much great teaching daily. I got to see like the bread and butter of obstetrics and gynecology, as well as lots of high risk and more specialist things. And I have no idea how that didn't convince me at the time to do obs and gynae. So I was gearing myself in many different directions, and I explored lots of other specialties. Like I wanted to be a urologist at one point. I wanted to do ENT. I settled on ophthalmology, which I thought I loved, and I did my whole medical school elective in that and thought I was building myself towards that. But when I did my obs and gynae placement, on my first day, I was the gynecology SHO on call, and I told the consultant gynecologist, I want to be an ophthalmologist, but I really do like obs and gynae, just so that they knew that I did want to engage like in the department. And they told me, oh, we'll convince you. And they did convince me to like completely change what I thought I wanted to do. It was just having worked in other places, I thought that department, that area and that team was where I really felt like I belonged, where I already knew it was something I enjoyed. But I also thought it was something I enjoyed and something that I could be good at as well. And those were really important things for me. And there's all the variety there. So I had intended to do an F3 year, which is a year that you do instead of going straight into training. After F2, most people take more time to maybe explore what they want to do, build their portfolios, travel. This is more and more common. Most people don't go straight into training. So I had intended to do that. And I thought, since I felt like 90% sure that obs and gynae was what I wanted to do at that time, I thought I might as well apply and try my best just to see how the process was. And once I had applied, I thought, actually, no, I really, really should try to really push myself to do well in it. So it felt like, to me, it was too late to actually build a portfolio for this. But even in that time between application, which is, I think it was in November when I applied, and my interview was in January, I think. In that time, I could already do a lot. Like I managed to do an audit in my GP placement, which was related to gynecology. And there was so much that I had already done in university and in other placements that, whilst not related to obs and gynae, helpful anyway in displaying like who I was as a doctor, like how well-rounded I was. So in interviews, they will always want to see evidence about teaching and audit and research and leadership. And even if all of those things for me weren't targeted towards obs and gynae, they were enough for me to show that I did have some skills in those areas. So it was for me. So even though the route seemed linear, for me, I did make a lot of different decisions. And in the end, like I'm confident, this is definitely what I want to do now.
That's amazing. I think it really does show that you don't have to know that you want to pursue obs and gynae from like day one of med school. So yeah, I think that's really good that you've highlighted that. I think we've got some questions, but just before we go to questions, I want to ask one of you to cover just what the training pathway is like. We have an idea about what the processes are and the steps. Like so if just one of you could go through it, because I think a lot of people might not actually know. Yeah, there you go.
Okay, I can cover that if you like.
And maybe you could talk about which stage you're at.
Oh, go for it. Was it Kate?
Yeah.
Sorry, it just froze there. I didn't quite hear the last bit.
So I just said if you could go through the training pathway,
Yeah,
so
no problem.
everyone just knows what it's like and
it's
how
a
many years
7-year
there
training program at present, and you do your F1 and F2. As you then enter, at present it's a run-through training program from ST1 to ST7, so specialty trainee. You might have noticed in other specialties like medicine, they'll have CT1 and CT2. That's essentially just meaning core training year 1, core training year 2, and often at the 3rd year they have to reapply for their specialty in that particular area. But in obs and gynae, it's run through, so you don't need to worry about any other interview until you become a consultant. The first 2 years are your most junior years, where you'll develop basic skills in medicine and surgery and obs and gynae. Hopefully by the end of ST2, you'll be able to do the majority of basic cesarean sections independently with a FY1, FY2 doctor assisting you. And by the end of your ST2 year, you should have got your first part of your exam. So the exam at the moment, in order to become a member of the Royal College of Obstetricians and Gynaecologists, is in 3 parts. The first part is 2 papers. They're written papers in terms of single best answers. That has to be done by the end of ST2 in order to progress to becoming a registrar. And then the second paper and the clinical, which is a part 3, has to be done by the time you've done your ST5, end of ST5. And that will then qualify you to have membership with the Royal College. Once you start becoming going to your intermediate years, that's ST3, 4 and 5, you'll start to develop particular areas of interest. So it might be gynecology, it might be particular parts of obstetrics, but you'll still be expected to maintain your basic competencies in cesarean section. Gynecological procedures include diagnostic laparoscopy, so looking inside the abdomen to maybe diagnose endometriosis or in an emergency or an ectopic pregnancy. But at the earlier stages, during those years, you'll be supervised. But as you progress into ST6 and ST7, there will be some things that you will be expected to do more independently and guide other junior doctors in your specialty through. And again, there's things like cesarean sections you'll be doing more complex ones, where it's more high risk, surgically more challenging. But again, that's in your senior years. A very small proportion of obs and gynae trainees may decide that they want to do a very specific part of obstetrics and gynecology. So there's 4 areas that you can become a subspecialist in. So those areas include gynae-oncology, urogynecology, reproductive medicine, and maternal fetal medicine. And that involves doing extra 2 to 3 years in addition to the 7 years to train in that particular area. So when you apply as a consultant, your job will be very, very specifically defined to that particular role. And the first 2 years of that will involve your clinical work. So say if you want to do gynae-oncology, the first 2 years will be doing very specialist gynecological operations involving cancer in a tertiary center, and the final year involves research. Now, often all these things are embedded together, but if you've got a higher degree or experience in research prior to that, instead of 3 years, it might be 2 years. And generally speaking, people will do subspecialty training after ST5. So you've got your grounding in your basic skills in medicine, surgery, and then you go into a particular area of focus. And then you hopefully get your ST6 and 7 done, and you will then become a consultant. Again, you don't necessarily have to know what you want to do. The majority of consultants at present work in a bit of everything, a bit of obstetrics and a bit of gynecology, and they'll have a specialist interest in a particular area. It might be reproductive medicine, fertility, whichever. But there's a difference between having a special interest in something versus being subspecialty trained in those 4 areas. So again, you don't necessarily have to know very early on what you want to do, but if you do, then it's important to make those right connections with people quite quickly. The other point is that although this slide shows everything being very linear, as Abrar said earlier, everyone's journey is very different. I never thought that I would take time out of my training to extend it beyond the 7 years. A lot of my colleagues we all interviewed together. They're now going to starting ST6 in August, whereas I'll be starting ST3. And for me personally, it wasn't about how quick it takes to become a consultant. It's about being in the right career and then eventually applying for a job that you're going to be interested in, that you want to do for the rest of your career. And for me, it was about having an academic career as well as a clinical career. And so taking that 3 years out was amazing. It just gave you so many opportunities to do a bit of traveling, get involved in education. You're not necessarily on a main rota, so there's not that pressure of constantly doing that clinical work and trying to fit in all these other extra things that are somehow expected of us, but yet you may not have time in your day-to-day work to do. And again, it's not just research that people take time out for. It might be a year abroad, it might be 1 year as an education fellow, and not to mention things like maternity leave, all those other things. So people take time out of their training program at any stage for various reasons.
Actually, now that you've just mentioned research, there's a question for you about how did you balance your research with your clinical work? So is it that you did clinical work just on its own, and then you did research after that? Could you maybe talk about that a bit more?
Yeah, sure. So I was quite lucky in the sense that when I took my time out of program, when you apply for time out of program for research, and if you do any clinical work, it doesn't count towards your training, but obviously it counts towards your experience. I was lucky at the Norfolk and Norwich to have an excellent opportunity with my consultant where I could do 3 days a week of research and 2 days a week of clinical. So getting involved in elective cesarean section lists, sitting in gynae clinics, assisting in theatre, and there's an element of service provision, but there was an element of learning at the same time to keep up those skills. And so that's how I balanced it with my time. But not all jobs are out there that offer that sort of time. Some might just say, right, you're doing 3 years completely out. And obviously with obs and gynae being a craft specialty, it'd be quite daunting to not do a cesarean section for 3 years and then go back to training all of a sudden. So I think if you do decide to take time out, particularly in the research role, try and be on the on-call rota to some degree, or as a supernumerary doctor where you may not be contributing to you don't have to be necessarily on the rota, but you're there to provide some service, and at the same time you're getting that clinical exposure. Because I think one of the things that I find challenging in the academic world of obs and gynae compared to my medical friends who are doing PhDs in, I don't know, rheumatology, cardiology, they could slip back into their clinical work quite easily, particularly clinic-based. But in a specialty where you constantly have to keep up your clinical skills on a practical level, it can be quite challenging if you haven't done it for a long time, dexterity-wise, but also just in terms of making sure you feel competent and comfortable to be at those particular skills. And cesarean section obviously is a basic skill that you need to master quite quickly, particularly in the first 2 years. So from that perspective, I was able to do both clinical and academic.
Nice. We've got another question, which is, so what does a day, what does your look like in obs and gynae? So because you're all at different stages, I guess you can give different perspectives on that. And also just going with that, how much of obstetrics versus gynecology do you do, and when do you start to, you might have mentioned this when you were talking about specializing, but when do you start to, choose one or the other? Or can you choose one or the other?
Only as a consultant.
Okay.
So about 66% of O&G consultants in the UK do both obs and gynae. As a trainee, certainly as far as I've been ST4, probably into ST5 as well, you are quite obstetric heavy because the need to cover labour ward, and probably ST1 and 2 particularly have quite a lot of time on labour ward to get those skills up so that you're independent out of hours. So my week typically looks like 1 long day on labour ward, maybe another session, so half a day on labour ward, a couple of antenatal clinics, maybe a gynae clinic, and then sort of pre-COVID, a gynae theatre list as well. Would be sort of a typical week. I don't know what the others have got to add to that.
I'd agree with Katie, exactly. That's exactly the same in my hospital too. And I think once you become more senior in the specialty, things can change. So I know that for gynae oncology, which is the most sort of surgical specialty, subspecialty within obs and gynae, those trainees will have a completely different rota to, say, the general trainee who's not on a subspecialist program, and their week might be say a couple of theatre lists, a couple of gynae oncology lists, and the odd labour ward. A lot of gynae oncologists, for instance, as Kate is saying, in terms of being consultants, won't do labour ward. They will focus specifically on their gynae oncology work because of the workload and the skills required to get to that level. But the majority will do obs and gynae. And some hospitals do have it separate. So the Norfolk and Norwich, we've got some people who are pure obstetricians, and they're on the very different rota, and some consultants who are pure gynecologists. But in district general hospitals, generally speaking, majority will do a bit of everything.
Nice. So I wanted to ask, what do you think are the pros and cons of obs and gynae? So far, you know, you've done a few years of training, but also you, Abrar, as someone who's just entering obs and gynae, and Anna, you know, are you on the fence at all, or were you ever on the fence? And you know, if there are any cons you're thinking of, what are they?
So this is actually something that came up in my interview. And I felt like my interviews wanted to see that I was really aware of the realities of this job. And having, like, I've only worked officially in obs and gynae for 4 months during that F2 placement. And a lot of the downsides that I feel a lot of trainees experience, things that I experience, is sometimes how rigorous the training is and how it's quite a lot of hours that you have to put into it. And for good cause, it's a specialty that the people that you are looking after, anything could happen at any time. So there always needs to be plenty of people working there ready to help. Obs and gynae as a specialty is one that doesn't retain all of its trainees till the end. There is a relatively high, like compared to a lot of other specialties, the dropout rate is relatively high, and there's a lot of things that contribute to that. I mean, I think the others can maybe comment on that a lot more. But one thing that I think also these are things that can be mediated, but in terms of also the stress of a lot of the roles that you hold as an obs and gynae doctor, you have a lot of responsibility for women, and for when it comes to obstetrics, they're woman and baby. It's a lot of things, a lot of complications can happen, and it's quite stressful dealing in environments where there can be a lot of risk involved. So I think a lot of those things are things that are probably the downside. For me, those are things that I think with time, you build the skills to deal with those things. You build the skills, the knowledge that you no longer feel a stress. You build the skills to deal with those situations. And stress is something that I see is involved in everything. So that's something that for me is far outweighed by all of the pros that I've observed and experienced. But it's something to be aware of, because without being aware of it, I can't prepare myself for like what I could experience. But yeah, that's just those are just the cons, but there are plenty of pros that I didn't mention there.
And just going off from Abrar's point there, she's absolutely right in exactly what she said. And some of the, I suppose, pros or cons, but just generally, I think what's important to remember is that when you see your consultant at the moment, the jobs that will be maybe available, or the way the jobs are being set up, what you see now may not be the case in 10 years' time. And increasingly, you know, as Katie's already said in the typing box there about shift working, consultant presence are trying to get 24/7 on the labour ward. So when you do become a consultant, you may still have night shifts. You still may be resident on call. You may not be the first person that the midwives come to if there's a problem, but you may be expected to be the resident consultant on call. And that's just the nature of the way medicine is going generally. I think everywhere they want consultants to be present as much as possible. So obviously things are changing from that side. And also, as Katie said there as well, about sadly the levels of bullying and undermining being quite high. I think it's being spoken. The good thing is that it's being spoken about with our Royal College. There's things that are hopefully being put in place, to tackle that. And we're probably at the early stages of all of this, but I think things are in place, and why it's happening, we don't necessarily know. There's obviously a whole host of reasons. And finally, just going back to some of the pros of the specialty, I think any area of medicine has got a variety of different ways, but the labour ward particularly, no one shift is the same, and it can be so different from one night shift to another, one day shift to another. And as you often cover both obstetrics and gynecology, you know, 1 minute you could be delivering a baby at an emergency cesarean section, the adrenaline is high, and then next moment you could be seeing a patient having a miscarriage on the gynecology ward. And so I think what obs and gynae does, it does develop your emotional resilience, and that's really important to know that it's okay, you know, when you feel sad about a particular case, or you know, these are the skills and qualities that you'll develop over your training program when you talk to your senior colleagues, or the experience that you get throughout of that. So
yeah, I think as a like from a medical student,
yeah, go ahead.
sorry.
Go ahead.
I was just going to say, you know, like I came
No,
in,
go ahead.
my mum is trained to be a midwife while I was doing my GCSEs. So I came into med school like having, that was like basically my only experience of healthcare was her being a midwife. And I always was interested in particularly obstetrics. And I remember going in and being like, I don't want to be that person who's like really into one specialty, like from the beginning. So I was like very much like wanted to keep an open mind about things. But when I did my obs and gynae placement in fourth year, I was just like, oh, I'm never going to get away from wanting to do this. And I think the thing that a lot of people have said to me is, because I have a lot of other interests, like with the editorial work and stuff, they're like, you know, obs and gynae isn't good for having a portfolio career. But I think, as you were saying, you know, things change, and this move towards, you know, being able to do 80% less than full time without having a specific reason. And I think there's just more awareness in general in medicine of like people's well-being and the way that they want to kind of construct their careers. So I'm optimistic that will, you know, there's never going to not be a need for shift work and on calls. And if consultants go resident on call, then that's, you know, that is what it is. But I think things can only get better in terms of the work-life balance and stuff. At least that's what I'm hoping.
Yeah, actually, I remember when the book This Is Going to Hurt came out, and there was a lot of light shed onto the obs and gynae field, I think. And I remember like lots of people talking about it. So do you think, you know, being in like having been in the training process for a few years now, you actually you know, these changes starting to being implemented in the process of helping trainees, whether that's working less hours or you know, having lots of supervisions from your senior members or senior staff around, you know, do you think there are like into place to give you a more work-life balance?
I think so. So as of August, I'm going to be 80%. With 100% on calls. So my average hours per week is 39.5. So 2 hours longer than your normal job person, but categorized as less than full time. So I'm going to have a Thursday off mostly to do my master's in medical education, but just for a little bit of breathing space in the week. And that's only become possible sort of this year. This is a new thing from the college. We'll call it category 3, less than full time, and it's when you don't have care and responsibilities or formally involved in something. So that's definitely a new change. There was a new e-portfolio brought in last year with a bit of a change of focus in the curriculum, looking a bit more broad-based and holistically, and along with that sort of the need to have an educational supervisor meeting every month, and for the last 12 months that's been really beneficial to me. I've had a really good educational supervisor, and I think there's a bit of an acknowledgement in this specialty as well that not everybody can be an educational supervisor, and not everybody's maybe cut out for the role, and perhaps allocating more trainees to the better educational supervisors for that level of support. So they're things I've definitely noticed recently. So the college is very much aware of the problems, the attrition rate, holding on to trainees, and I think things are gradually sort of coming in to improve.
Mm.
Anyone else?
I think there's no denying the fact that obs and gynae is hard. I think it is one of the most difficult specialties, physically, emotionally. You know, you go home after a long weekend or some nights and you're just absolutely knackered. But I think that's with anything in medicine and surgery. I think if you're dedicated and you want to progress forward, of course you're going to put the effort into be the best you possibly can. But I really wouldn't let that put you off in applying. And I know obs and gynae sometimes gets a bit of a reputation for maybe not having a work-life balance, but I think as long as you've got your own awareness of how you switch off, however that is, you know, whether it's taking time out your training to take a bit of a break from the whole roller coaster, whether it's actually saying to yourself, right, hopefully I might finish late. If I finish late on one day, then what am I going to do to, you know, relax and just get away from work? I think that's more important rather than necessarily finding other ways to achieve that balance. But I definitely think in obs and gynae you can, you know, work intensely hard during your shift, but yet you can find time to do other things as well. And for me personally, taking 3 years out of my program was one of the best things I could have done. I don't think you realize how tired you get with medical school, F1, F2, and then you're on this roller coaster of constant e-portfolio, getting things signed off, next stage. But just having that time to just breathe a little bit, I think that was really useful. So you can always find different ways to switch off or balance your work, whether it's in the short term on a daily basis, weekly basis, or in the long term by taking some time out of training.
Yeah. I would definitely agree with like what Babu and Katy have said about like emotional resilience, but also kind of emotional roller coaster it can be. But I think what also I think is when I was working in obs and gynae, I also experienced those days where you're involved in a delivery and you have this high, and then you're involved in like, I don't know, like a late miscarriage, and you feel like how am I going to help this person get through that very difficult experience, and how am I going to help myself experiencing this, because I'm also a human. I'm also going to feel burdens of this. So I think those are actually things that you actively work to build. Nobody is just born with those skills and that ability to kind of withstand all kind of pressure. I think those are things that you develop and you have to actively do so. So I feel like in 4 months, I built that thing. I built some of those skills. And now I don't feel like I'm nowhere near those skills, but consultants have those skills. Trainees have those skills. It's something that you build to kind of help counsel people through very difficult experiences in their lives. And that also you can use those skills for yourself. And I think also obs and gynae, what is kind of attractive in one way is that, do you want to be the person that does help people in those very difficult experiences? And I feel like myself that it's for very difficult things. Like, I don't know, Babu, you were talking about endometriosis. Endometriosis is something that I find when I've seen women with endometriosis, it's so difficult because of all of the pain those women live with. Often people feel misunderstood for years or dismissed for years. And I feel like building those skills to talk to people, to help them see that you understand, that you want to do something to help them, that's incredibly satisfying. So I feel like that is what I want to be doing. I want to be able to do those things. So I think even though it's stressful, I want to know how to do those things to help people in that way.
I totally agree, Abrar. And some of the most rewarding parts of my job, or the most rewarding interactions I have with patients, haven't necessarily been the happy endings. It's been the difficult situations when you've made it a little bit better. Whereas anybody can do a cesarean section, anyone can deliver a baby safely. I don't think patients actually always remember who's done that, but the thank you card, just sometimes the ladies who have had a really tragic outcome, or some of your gynae patients that are really struggling. So yeah, which wasn't what I thought going into the job actually. But they could be some of the most rewarding parts.
And I think obs and gynae, the good thing about obs and gynae is that it really does test your communication skills to the maximum, really, because often you're communicating sometimes in very difficult or challenging circumstances. If someone is labouring and there's an emergency, you need to deliver that baby in the room or via cesarean section quickly, then you have to act quickly, but you also have to communicate really sensitively, and that's not always easy, particularly if the woman isn't expecting any medical intervention or any sort of input from a doctor. And the other side is things like breaking bad news. And obviously breaking bad news can vary saying to someone they've got cancer to explain to them that their scan shows that there's been a miscarriage. So it does test your communication skills in different environments, but also to different degrees as well. And as Katie said, it's not necessarily about the positive side. Is often the most rewarding times when you go home and you think, have I made a difference to that person's life? May have been when the outcome hasn't unfortunately been positive.
Sorry, I don't know if I missed this or not, but we've got a question from Erin who's asking about whether or not it's easy, or I guess what the transition's like from when you leave to take a few years out, if that's to do research or if that's just for because you've got like family things. How is that transition when you come back, and are there like support system to help you with that?
So for me personally, taking time out was a relatively easy process. I applied for a job as a clinical research fellow, so it was an advertised job. When you apply for a job of taking time out, whether it's a research fellow a research fellow or an education fellow, you obviously go for your interview, get your job confirmation, but then you have to apply to take the time out with your deanery, and it's your head of school that will agree that request. I know that in recent years they have tightened down on what you can take time out for, but again, going back to the attrition rate and what is the college trying to do to help with that attrition rate, I think one of the things that they're trying to do is help people take that time out of their program to do something useful. So you apply to take time out. Often you have to submit reasons as to why you want to take time out, how will it be useful. And for me, because I was able to do some clinical work and research work, the transition of going back into clinical work, it was challenging, but maybe it could have been more challenging if I wasn't doing any clinical work at all. I was lucky to have supportive consultants and registrars who guided me throughout my 3 years and developed me, because I was at the stage of ST2, ST3, and that's quite a big jump between those years, because you're going from being supervised to a little bit more independence. There's a bit more expectation on what you should be able to do without necessarily always having someone over your shoulder. And I think that can be quite challenging. So it depends on maybe when you take your time out would determine what challenges you will face. Maybe in ST5, taking time out to go to ST6, the challenges might be very different, because hopefully at that stage you've developed a good grounding in your basic skills in obs and gynae, compared to an ST1, ST2, where you're still developing those skills, you're still quite naive in the whole specialty. In terms of returning back to training, one of the schemes or one of the initiatives that's out there at the moment is you can do some shadowing for 2 weeks before you return, as you return back, and you'll be a supernumerary member of the team, and you're observing, asking questions. Again, it's better than nothing, and that 2 weeks you're getting paid to be there, and you don't do that before you return, you do it on your return day. There's often a lot of support with individual deaneries as well in returning back to training. And again, returning back to training might be for various reasons: maternity leave, and like Katie's just said about keeping in touch days. But there are plenty of opportunities that support networks available there to be able to do that.
I think it is tricky. I haven't gone out of training and come back, probably because I am quite apprehensive about that and have thought about taking time out. But the amount of doctors, and probably more so registrars, that go on maternity leave during their registrar training and come back, it's doable, it's done. It's very common. There's very few people who will start at ST1 and come out the end at ST7 in 7 years. The vast majority of people, because it's quite female dominated, I suppose a lot of people have maternity leave, but also the amount of people that do research and different fellowships in that time, it is expected that you will have to go out and come back at some stage for whatever reason. Yeah. the obs and gynae is the career where you're all told constantly about your fertility declining at age 35. So as a 32-year-old sat here, you can hear the tick, 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 tick. And there's that expectation that you probably will get on and have your kids before you're in your late 30s, because everyone's so aware of that. And as a graduate entry medic, I didn't graduate, I was 26. So that awareness. So lots of registrars have children, lots of registrars come back less than full time. Just it's less of an issue for them. The tick,
But I did.
But then one of the
Sorry, continue.
Just because one of the male registrars in the hospital I'm going to next is less than full time. And I think that's really progressive, and we need to be encouraging that less than full time working isn't just for the girls, and to normalise it a lot more for our male colleagues to do that as well.
I was just going to say what you said about how it's female dominated now in terms of like the trainees, and how a lot of people will go into during their training if they choose to. I think for me that was a big relief to see, because I saw all of my consultants, well, not all, but a lot of my consultants were women who had children. A lot of the registrars I worked with had young children, and I felt like it is possible to do this. It's when we talk about work-life balance, yes, your work-life balance doing obstetrics will be very different than doing GP or maybe doing rheumatology. It's going to be different, but that's not impossible. And you just have to see the cohort of colleagues that you'll have, or people that you see working in this field, to see how different people manage their own work-life balance. And that's not just for families, that's also people that work less than full-time because they have other things that they do on the side. People that, well, I don't know, like Anna, you're talking about all of the things that you're interested in terms of like journalism. There are people that have completely non-medical careers on the side that I don't know about people in obstetrics, but I know people in other specialties who have very different things that they do, and they work less than full-time to kind of manage their other interests and other incomes. So I think that's one thing as medical students we never get taught about, we never see.
Yeah, because you don't see the other things the consultants do when they're not there. So the amount of them that disappear to do private work and sort of teaching roles and management and all those sort of things that are in their job plans. And people are surprisingly open to go, what does your job actually look like? What's in your job plan? Because you don't see the bits where they're not clinical. And we know talk about being a trainee and training for a long time, but ultimately you're going to be a consultant for a lot longer than you're a trainee. So kind of having those conversations and say, can I just find out what you actually do? Because that's what you essentially sign yourself up for in the long term.
Thank you so much.